journey of a variety of got it. Okay, let me just share my screen.
Yeah, you can share your screen.
Yeah. Let me know when you start seeing my screen.
Yes.
You can see my screen?
Yeah.
Okay. All right. So again, good evening to you all there. I'm here in Philadelphia. It's morning here, Saturday, and it's a very nice morning here with a lot of cherry blossoms around me. And it's really a pleasure to be here and honor to be speaking to you all. And I'll be talking to you all today on head, face, and neck tumors in children mainly. This is a very vast topic, and by no means I can complete, show you each and every of these, entities, but I'll try to show you some of the major or the most common entities, which will be, across the board, whether you're practicing in India or, anywhere else, if there are people who have joined in from other parts. So let's get started. And okay, I have to just move this. Okay, so I'm obligated to do this for any of my presentations. I have no financial disclosures. But the main disclosure that I want to start with, the topic is, I have trained in India and I have, practiced in India, and for any of the conditions that I'll talk to you, or most of the conditions that may present, tuberculosis is a major consideration. And we all know that it can be a real master mimicker. So think of tuberculosis in the correct setting, always have it in the back of the mind. Is it something that TB can do and can mimic and do the appropriate things for the management? So having given this major disclosure, I want to tell that in the next 40 minutes or so, mainly what I'll be doing is discussing some of the common pediatric head, face, and neck tumors and describe their imaging features, and also to be able to recognize some common tumor mimics. So let's get on the journey. So I'm going to be taking an approach based on the type of tumors. We'll start with the major group of malignant tumors that lists all these entities. These are the major entities. Then I'll be talking about the group of benign tumors, which are very common in practice, and you can see them with the group of vascular and nerve sheath tumors. And then the other group that I will touch today because of the pediatric world is going to be congenital tumors, like the dermoids, epidermoids, teratomas, and lymphatic malformations. We will look at some other kind of tumors which cannot be classified, or they are on the bridge of these kind of benign versus malignant. Some of them there is question whether it's a neoplasm or it's just an inflammatory response. And then we will look at some tumor-like masses. So starting with first the group of malignant tumors, and these are listed in the order of their incidence in the pediatric age group. So we'll start with lymphoma. This is the most common head and neck malignancy in children. Among the two types that are more common, the Hodgkin's and the non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma accounts for about 60% of these tumors. It is usually a disease that occurs in the children. It is usually in the younger children, usually in the first decade between 2 to 12 years of life. And it can happen, again, it has a peak in the adult population as well. Though it is lymphoid tissue that gets involved, extranodal lymph node sites, extra lymph node sites are common in non-Hodgkin's lymphoma, particularly involving the Waldeyer's lymphoid ring. It occurs in osseous structures and facial structures, especially the paranasal sinuses. And the subtypes that we need to know more commonly in the pediatric group include the Burkitt's lymphoma. We have the diffuse large B cell and anaplastic cell type of non-Hodgkin's lymphoma. And talking about Hodgkin's lymphoma, it is mainly a disease that affects the adolescents and young adults. It's very rare to see Hodgkin's lymphoma in kids younger than 5 years of age. And Hodgkin's lymphoma typically mostly is seen in the involving the lymph nodes most of the times, and rarely it can affect organs other than the lymph nodes, whereas the reverse is more common with non-Hodgkin's lymphoma. And histologically, the nodular sclerosing variety is the most common type, and you can have Hodgkin's lymphoma involving not just the cervical lymph nodes, it can be involved the mediastinal lymph nodes and also lymph node groups below the diaphragm. And we use the Ann Arbor staging to kind of stage or see the complete extent of Hodgkin's lymphoma. And this Reed-Steenberg cell, if you all remember from our histology, is like the sine qua non or the very salient feature of Hodgkin's lymphoma. So we'll start with this one. So usually Hodgkin's lymphoma, and I want you all, I have written the age of the patient and the presentation wherever it has come, and please pay attention to that because that will be one of the features which will help you narrow your diagnosis or tell us about, what is the more common tumor that will happen in that age group. So this 17-year-old male, he presented with a painless neck mass. And you can see here on the CT scan with contrast, this is the left-sided large, it's almost like a soft tissue conglomerate of the lymph nodes. And we have an MR here in the coronal plane that shows that lymph nodes of, they are all coalesced together along involving the entire cervical chain. And please notice there is no surrounding edema or inflammation, which usually accompanies the inflammatory and the infectious etiologies of lymphadenopathy. So Hodgkin's typically presents with a firm or a non-tender, painless, neck mass. It's usually unilateral, but can be bilateral, can involve not just the cervical, but can involve mediastinal lymph nodes and lymph node groups below the diaphragm. And we use FDG PET to assess the disease extent and to monitor the response to treatment. So here is an example showing the increased uptake or activity on the FDG PET study. And now this is the example of, I think, another case who also had Hodgkin's lymphoma, and you can see the activity of the uptake on the FDG PET study. And it is one of the very heartwarming things to see in radiology because we have made good success with this, that post-chemotherapy, usually even the bulkiest of diseases, it melts away. And it's one of the, very, very nice, success things that we can see the effect of chemotherapy. And a lot of them, there is near complete resolution. This is just with 6 cycles of chemotherapy. You can see that there is reduced uptake and there is decrease in size of the lymph nodes. And actually the change in the FDG uptake, this precedes the tumor volume changes that you can see by anatomic imaging or structural cross-sectional imaging. The FDG PET is more sensitive and precedes or shows the changes response to treatment earlier. Sometimes you can see on imaging, you can still see some residual lymph nodes, but when you correlate it with the FDG PET, you will see no activity. So that means that it's a reassuring response to chemotherapy. And we now move to non-Hodgkin's lymphoma, and one of the common subtypes of non-Hodgkin's lymphoma, which you see, is the Burkitt lymphoma. Now, this is a young patient. You can see is a 4-year-old boy presented with this huge mass. And as I had mentioned earlier, non-Hodgkin's lymphoma likes to involve the lymphoid tissue. And you can see this was actually, a large mass in his nasopharynx. It was almost extending to the parapharyngeal, in the pterygopalatine, and as well in going into the masseter infratemporal fossa. And notice this was showing enhancement. This is ADC map, which is showing, because it's a very cellular tumor, it is showing restricted diffusion and low signal on ADC. And this is the intense uptake that you get on the FDG PET correlated image. There is another area which non-Hodgkin's likes to, or the Burkitt's lymphoma likes to involve, which is the mandible or the jaw lesions. And this is one of the few radiographs that I'm showing in this talk today. And you can get these painless jaw lesions in young kids, and you can have the involvement of the dental roots, and it can lead to like these floating teeth sign that you see on the radiographs. So think about this in a young patient, with a large painless mass usually arising around the lymphoid tissue. So a young patient with either a painless neck and mediastinal lymphadenopathy, history of fever, night sweats, weight loss. If you have ruled out tuberculosis in the setting in India, then you should consider a lymphoma as a diagnosis. Okay. So that was lymphomas, and I'll move on now to the second most common head and neck malignancy after lymphoma, that is rhabdomyosarcoma. And this accounts for nearly about 20% of all pediatric head and neck tumors. It's a malignant neoplasm of the striated muscle, as the name suggests, but it can arise from structures, any of the structures which are derived from the mesenchyme. And histologically, there are 4 types, of which the embryonal and the botryoid type are more common in infants and children. You can have alveolar type of rhabdomyosarcoma, which typically has the worst prognosis, and there is a well-differentiated variety which is more common in adults. Majority of the cases that you see are going to be in the children are going to be embryonal type of rhabdomyosarcoma. So rhabdomyosarcoma has been divided based on the location and the management and the prognosis into 3 major groups. The first group is the orbital rhabdomyosarcoma, and then the third group, which I'll talk first, is the parameningeal type of rhabdomyosarcoma. And the orbital, as the name suggests, is localized just to the orbital, usually arising from the extraocular muscles. Because of their location, it gets the clinical symptoms arrive earlier, and that's why it is diagnosed earlier. They usually present with proptosis, as you can see here, and this has a favorable prognosis. And the worst prognosis is with the parameningeal type. Parameningeal, as the name suggests, these are tumors which do not mean that they've already invaded the meninges, but they are very close to the meninges. It's very close to the dura, so they have a potential for intracranial extension and perineural spread more commonly. And the location mostly is such that the resection is a complete resection is not possible in most of these cases. That's why they have the worst prognosis. And the group in between is the non-orbital, non-parameningeal rhabdomyosarcomas, which come from all other regions of the head, face, and neck. And these are usually more amenable to complete surgical excision, so also have a favorable prognosis. So I'll start with this case of rhabdomyosarcoma in this 12-year-old female. And this belongs to the group of the parameningeal type of rhabdomyosarcoma. And you can see it is pretty evident here in this case, very large lobulated enhancing mass, which is probably centered kind of more on the nasal and the maxillary sinus cavity, which has extended superiorly and has also invaded the anterior skull base. And this is where it is actually sitting very close to the meninges. If it is left untreated, these can go along the foraminal, it can have extension along the nerves, and perineural extension is very common along the branches of the trigeminal and the facial nerve, depending on the location where they are. Here is a CT that shows the extensive bony destruction. And these are the FDG PET images. This was taken a few weeks after the treatment chemotherapy had already started. And you can see by this time, after a follow-up, that there has been actually decreased uptake. And many times, because of the location, they will aim for at least some kind of a partial resection, and they will need adjuvant treatment later on. So the uptake of is variable. These are usually heterogeneous type of tumors, and they do show restricted diffusion patchily in the portions, and they do show enhancement most of the times. The SUV, or this value that you can get on PET on the initial diagnosis time, can be a predictor for the prognosis. And the higher the SUV, the pre-treatment value, it can portend bad prognosis and which have a higher incidence of recurrence. And now this is a more circumscribed orbital rhabdomyosarcoma. I think this was a very young patient. I think my text is not showing. If I remember correctly, this was, I think, just about a 5 or 6 year old female with this very quite circumscribed mass lesion in the superior medial orbit. You can see the enhancement here and see the displacement of the globe. And that is why they present early with symptoms of either proptosis or inability for or restricted extraocular motility. And this is now the third group, which is the non-orbital, non-parameningeal rhabdomyosarcoma. And these are usually painless masses. And this was a very interesting case. I remember this was a 3-year-old actually got a, they saw a lump which was noticed after a trauma. So they got the CT scan, and then we were surprised to see this very well circumscribed mass, which was no relation. The trauma was just what brought attention to this mass. And you can see its heterogeneous nature on MR and enhancement. And also there was patchy restricted diffusion and uptake on the PET, FDG PET study. So this one, I think, had a pretty good, was able to be resected completely and had a good prognosis. So ideally, you want, in terms of management, you want complete excision is preferable, but it depends on the location, and you don't want to have any significant functional or cosmetic loss. It depends on the location mostly, whether you can get a complete resection. If you don't get it, then you need to support it by adjuvant chemo or radiation therapy, depending upon the subtype of the tumor. Because of their location, the non-orbital, non-parameningeal tumors, they are amenable to complete resection and have the best prognosis, and the parameningeal variety have the worst prognosis. Okay. So we will now move on to the next group of primary malignant tumors, which is the retinoblastoma. This is the most common malignant tumor affect intraocular tumor in children, majority of whom will occur below age of 1 year. Almost 11%. This accounts for about 11% of tumors in the first year of life. And a majority of these are going to be sporadic, but there can be about 5 to 10% which are familial and inherited in an autosomal dominant manner. And the mutation is on the RB1 gene. It's on the long arm of chromosome 13 that results in this germline or RB1 mutation, which is responsible for the familial type of retinoblastoma. These usually present with a white eye and lack right reflex. You can see, and as in this picture here. And they belong to the group of small blue cell tumors and are highly cellular and will be showing diffusion restriction on imaging. So here are the typical examples of retinoblastoma on magnetic resonance imaging. We hardly now get, sometimes you may still get them present on CT, where you will see them typically as an intraocular calcified mass. Whereas here you can see them on T2, you can see them as a heterogeneous, mainly T2 dark and bright areas. There is homogeneous enhancement here. And this is the susceptibility weighted imaging, because they can have calcification or mineralization, which shows susceptibility or dark signal on these images. And this is the ADC map, or a part of the diffusion derived from the diffusion images, where it will show dark signal because of their high cellularity. This will be diffusion restricting tumor in the globe. In a kid less than 1 year of age, it's more likely going to be retinoblastoma. Now, I have a question here for you. These are 4 different cases of retinoblastoma. And from these, I cannot see you all, but you can just ask yourself the question. From these, how many do you think are bilateral retinoblastomas? So I will just pause here for a few seconds. You can take a look at these 4 different cases. And which ones do you think are bilateral? So I'm sure a majority of you will see that this case, the case 2 and MR case 3, are bilateral. It's pretty straightforward. Just what about this case on CT, which is showing this calcified mass very clearly in one globe? And what about the other globe? You may think on imaging, probably it is just unilateral. And same thing here on another case, which has, you have just a very small nodular kind of lesion here in the left globe. And what about the right globe? So you may be inclined to think that these two, the first and this last case, these are unilateral retinoblastomas, but I have to tell you, these are all examples of bilateral retinoblastoma. The point here I'm making is that there can be nodular lesions which are still, we may not be able to detect them by our current cross-sectional imaging techniques, but they can be seen on direct examination or slit lamp or the ophthalmoscopy examination. So it's quite common. That's why it is very important to look into the clinical or the ophthalmoscopic examination, that it could be whether it is a bilateral, and imaging may not detect them very easily. So just that has to be kept in mind. Because when you see bilateral, you try to think of whether there is a germline mutation, whether it is familial, and whether there are other sites of involvement, which I will just talk to you in a minute. So if it is bilateral, as we are seeing examples here, then it is most often going to be familial. And you have to consider, you have to always look towards the suprasellar region and the pineal region to see if there are additional mass lesions. So you call it a trilateral retinoblastoma if you have both bilateral retinoblastoma plus either the suprasellar lesion or a pineal lesion. Then it'll be, that combination will be trilateral. But when you have both globes, the suprasellar and the pineal region involved, then that will be a quadrilateral retinoblastoma. So you're seeing here examples of just the trilateral. In this case, they had just the pineal mass. This was suprasellar, and there can be combinations where you have both the pineal and the suprasellar. Pretty rare ones, but I think we did actually have a couple cases that I can remember over the last 10 years that I have been at CHOP. So the next entity I'll talk about is nasopharyngeal carcinoma, very common in adults, but only a very small percentage of children will have it. Usually they are adolescent and older children, males, more common, and it is the Asian kids or the older who have a more propensity to get this type of carcinoma. And it has a strong association with Epstein-Barr virus, and like it presents in the adult population, you are always told that whenever there is just unilateral mastoiditis, always think if there's something obstructing the eustachian tube, and the classic location is the fossa of Rosenmuller, is the nasopharyngeal region where this carcinoma originates very typically, and is notorious to have spread along has got perineural spread and has propensity to have skull base invasion, as you can see in this case here. And majority of them are the undifferentiated type in children, and also notice the very high uptake and lymphadenopathy which is involved, and that will be very important to see for staging of these nasopharyngeal carcinomas. So it is difficult to differentiate, the histological subtypes by imaging, whether it is, squamous cell carcinoma or rhabdomyosarcoma, but the location in the nasopharynx, more aggressive intracranial extension, perineural spread, in a older patient, male and of Asian descent, would favor a nasopharyngeal carcinoma. Thyroid carcinoma is rare in the pediatric population, but can be seen in some of the adolescents and female patients, more common. And when you see lymph nodes with a necrotic center and pathological lymphadenopathy with necrotic centers, you usually have to think of where it is coming from. Is it a metastasis? And you have to search for the primary. One of the common sites for these would be the thyroid. And papillary carcinoma is the most common type of thyroid carcinoma, and it will usually present as painless neck mass from these metastatic lymph nodes. And here on the right of the screen, there are images from iodine 123 SPECT CT. This is in an unfortunate case, they had thyroidectomy and treatment, but there was recurrence and uptake. You can see the uptake in the thyroid bed, as well as additionally in the other lymph nodes chain that is seen on the SPECT CT here, which was 6 months after their initial surgery. So it is quite notorious for recurrence, and you make use of iodine SPECT CT to identify the recurrence and even the lymph node involvement in these cases. Salivary gland tumors, now again, this is a smaller group which can occur in children. It can be benign, with pleomorphic adenomas with very bright T2, or they can be, malignant tumors, which are usually of the mucoepidermoid carcinoma. They're generally low-grade malignancies and have a good prognosis, but if it is adenoid cystic carcinoma, it's unfortunately has a relatively poor outcome. And the recurrence rates are higher in pediatric age group than in adult age group. And quite often, it's pretty late for presentation. You can have small primaries, and the metastatic lymphadenopathy can be larger than actually the size of the primary. So unfortunately, it can sometimes be late in actually diagnosing these tumors. But fortunately, this is a very small group of malignancies in children that you see. A very important entity that whenever we are talking about pediatric tumors, you have to remember about neuroblastoma, either primary or secondary. So primary is in the neck is usually less common, but the neuroblastoma can arise from the primitive neural crest cells wherever they are present. They are usually present along the carotid sheath, in the carotid sheath. So when you see a mass, which is like kind of in the region of which is posterior to in this aspect of the carotid space, you have to think about this entity. And very commonly, they may sometimes in the children, they may present with a mass in the carotid sheath with Horner syndrome, and that should be your hint to exclude neuroblastoma. And just about 1 to 5% of all neuroblastomas are primary cervical neuroblastomas. And more common than the primary are metastases from adrenal neuroblastoma, the most common location. And you can see here, these are images of different patients from the CT scans, and the very speculated appearance and bulky lesions are usually the hallmark of neuroblastoma metastasis. They love the region around the orbit and the craniofacial regions, even the calvarium is very typical, when you see a permeative pattern, or you can see the sunburst pattern associated with these bulky metastases. And usually the kid may present with, either signs of what you call a raccoon eye with very, you can have this ecchymosis around the periorbital regions. And these are images from MR showing these bulky neuroblastoma metastases, which show diffusion restriction. And this is an MIBG scan, and you can actually get what are called super scans, because there is extensive metastasis in the craniofacial, axial and appendicular skeleton. And on MIBG scan, this can actually look as the super scans. So this is more common. Metastatic neuroblastoma in the face, head, face, neck is more common than primary cervical region neuroblastoma. Now we'll turn to some uncommon entities in the malignant group, which are the peripheral primitive neuroectodermal tumor, or Ewing sarcoma. And this entity, which I learned about only just a few years ago, which is called the nut carcinoma. It used to be formerly called the nut midline carcinoma. So we are familiar with Ewing sarcoma in the bones, in the osseous structures. But you can see this in the craniofacial region as extensive large masses, which they usually have some kind of marrow involvement, and then are bulky, associated with bulky soft tissue masses. And they can be really aggressive, aggressive can involve, it can have bony destruction and infiltration into surrounding tissues. It's a small blue cell tumor, so it will show restricted diffusion and quite aggressive looking heterogeneous mass like lesions. And usually they're young and 2 years of age. And they grow very rapidly and metastasize. And they usually have, a few necrotic centers by the time it presents, and commonly infiltrate adjacent spaces. So think of something extremely aggressive when you have a component of marrow involvement and aggressive destruction of surrounding structures. This should be an entity that should be kept in mind. Sometimes they are considered as, these are actually separate entities, but the thing that they share in common is the translocations, which are similar to the Ewing sarcoma on the chromosome location of T1122 translocations. And that's why they are grouped together, the peripheral primitive neuroectodermal tumor and the Ewing sarcoma. And this somewhat rare entity called the nut carcinoma, the name nut is derived from the presence of nuclear protein testes. That's why it's called nut. And initially it was thought to be, or it is more commonly in the midline structures. It's not necessarily just in the region of the face and the neck. It can come in other tumors. Actually, the thorax and mediastinum are also pleural locations from where you can get this tumor. Usually it affects older males more commonly. And in the neck, it is, it's commonly seen here. It's an example which is involving actually the parotid gland. And they are very rapidly growing. You can get from the history that this was just a few, from a pea size, it can go to like a golf ball size in just a matter of weeks. And they metastasize rapidly. And unfortunately, it's not a tumor that is very sensitive to chemo radiation and is not associated with a very good prognosis. You can see the uptake here in the primary lesion as well as in the metastatic lymph nodes on these composed maps, as well as in the source images here. So it's a tumor with a bad prognosis, but think about this in an aggressive looking tumor in some of the older patients, usually more in males. So we are now done with the malignant group, and we will move to the group of benign tumors. And I'll be highlighting and touching on some of these vascular and nerve sheath tumors. So here is the example of hemangioma. This is the most common benign tumor, and commonly seen in infants. More it is and is prevalent in the head and neck region. We have a new ISABA classification. So based on their the pattern of the evolution, they can be classified into the rich or the rapidly involuting congenital hemangiomas, or the non-involuting congenital hemangiomas. Majority of them, they will grow in the first year of life, and they will be followed by involution with slow regression, whereas some of them may remain non-involuted. Now, it's because it's very intensely vascular. You can see homogeneous enhancement of these lesions, and you can see flow voids within them. And these are examples of the ASL perfusion imaging, MR imaging, and because of the high perfusion, you have uptake within these hemangiomas. And when you see one hemangioma, you want to see if there are multiple, and also the location where this hemangioma is very critical. So most of the hemangiomas, which we see, they may involute or can be left alone without treatment. But there are two varieties of hemangiomas which immediate treatment is necessary. And you can describe them as one is like a life-threatening. So one is this life-saving hemangioma, which needs treatment. That is the hemangiomas which are around the glottis or the laryngeal. They usually will present with stridor, and they can cause obstruction. So that is why these hemangiomas need to come out. So this is the life-threatening sort of hemangioma, which needs attention. And the other one is the sight-threatening. the hemangiomas in the periorbital regions, which can grow, and they can actually, the child can, it can obstruct the vision, field of vision, and the child can develop amblyopias and scotomas. So it is important that these get treated because of their location and because of what they can do to reduce the function of the child. So the life-threatening and the sight-threatening hemangiomas are the ones that need to be treated immediately. And there is another setting where you can have multiple hemangiomas in the patient, and you need to think of the facies association. This is a acronym which includes all these abnormalities listed here. So posterior fossa malformations, hemangiomas, they're typically on one side, and they also commonly involve the trigeminal nerve distribution. Like you can see in this case here, multiple orbital. If this is going towards the orbital apex, you have cavernous sinus, you have CP angle hemangiomas, and this other patient, you can see periorbital and cheek or the face hemangiomas. And these are the perfusion maps. They have just been color coded, and you can see the high perfusion within all the hemangiomas that you can see here on the cross-sectional imaging. The next group of benign tumors include the venous malformations. They are low flow anomalies. Venous malformations do not involute, unlike the hemangiomas, which we just saw. And it has a presence of venous lake and phlebolytes. So you can see calcifications here in this patient, this CT that you can see here. And this is an example of a venous malformation on MR imaging. And on MR, you can see these phlebolytes or calcifications can be seen as dark signal areas, and you can employ the gradient echo or susceptibility sequences to check for the presence of phlebolytes or calcification within. And following this, I want to talk about this entity, juvenile nasopharyngeal angiofibroma. This is a benign tumor, but can be locally aggressive. It affects adolescent males typically, and the common presentation will be epistaxis and nasal obstruction. And recent studies have shown that VEGF factor and chromosomal alterations play an important role in the development of JNA, and even androgens have a role. That's why the association and its incidence in males is so typical. And it also has an increased frequency in patients with familial adenomatous polyposis. So this is a CT scan which shows this mass, which is typically centered around the pterygomaxillary fissure, and through the pterygopalatine fossa. It can have extension in all 6 directions. It goes into the nasal cavity, and that's why it can present with proptosis, can go posteriorly towards the skull base, into the orbit, into the infratemporal fossa, and also into the parapharyngeal regions. And these are very vascular, locally aggressive tumors. Here, this is, it's showing in another plane, just showing the extent of their spread. This is on MR, and these are, because they are highly vascular, they show intense enhancement, and it's the characteristic location. Look at the normal pterygomaxillary fissure on the right side, and this is where it started, and then can go in multiple directions once it's spread. On radiographs, the characteristic bowing of the posterior wall of the maxillary antrum on lateral radiographs was characteristic, and bony remodeling and destruction is seen on CT, and on MR you can see variable intensity on the T2, but because it's highly vascular, you can see flow voids and intense enhancement and aggressive local destruction and spread. And because they are so vascular, before they get resected, the norm is now to have embolization to reduce the vascularity of the tumor, and then followed by the resection. And these vascular tumors, they usually recruit the supply from several branches of the internal maxillary, ascending pharyngeal, and palatine arteries. And often we see a lot of anastomotic connections from the external and internal carotid artery feeders to this mass lesion. You can see this example of a successful embolization of the JNA. So typically the pterygomaxillary fissure is the location, but there can be sometimes tumors which may not be in the classic location, but whenever you see something with very high flow voids in the nasal region, And in a male adolescent presenting with epistaxis, you always have to think of JNA. And classically in the exams, this has been a very typical question is, will you biopsy this lesion? And the answer is no, because of the high vascularity, it can be really catastrophic when you do this. So that is the reason why you need to do the cross-sectional imaging, get to and see the spread, idea of how extensive this is, and do an embolization prior to it. And this is one rare example that I have, which did not show that typical vascularity of that would be associated with the JNA. This is more of an exception rather than the norm with JNA. Moving on, another mass lesion, which may rarely be seen, again, surrounding in the region of the carotid space. It could be a schwannoma, and particularly it could be either isolated, sporadic, or could be associated with the neurofibromatosis 2. And you can see that they are like solid lesions with some heterogeneity inside, and they can be having some non-enhancing cystic or necrotic areas. But notice the well-defined margins and the location in near the carotid sheath region. And I'll quickly run on some other benign entities. These are plexiform neurofibromas that you see associated with neurofibromatosis 1, numerous in the scalp. They are characterized by this classic target appearance on when you get them in the axial plane in the cross-sectional imaging, and they can be really extensive unfortunately in these cases with NF1. You can also get optic pathway gliomas with NF1 variable involvement of the intraorbital, the cranial, and the chiasm involvement with an optic pathway involvement with NF1. And lastly, touching on some of the congenital tumors. So with these large, when they have large masses, congenital tumors, we can diagnose them on fetal imaging. And one of the most common one is the lymphatic malformations. They usually present with large, typically multiloculated cystic masses, and they can have fluid levels in them. And mostly when you do imaging, unless they are infected or you've done some treatment, they do not show any nodular or solid enhancement. So this is an example of a lymphatic malformation on a fetal MR. This is how it was when the kid was born, and this is the MR imaging. You can see, T1 areas of bright signal here and T2 dark signal because of hemorrhage and layering that can happen with these large, macrocystic transpacial lymphatic malformation. And these are actually, now we do sclerotherapy for them, and they have very good results with the sclerotherapy treatment. The next one is the group of dermoids. These are usually inclusion cysts that occur. One of the most common sites is around the orbit. You can have them along the nasal glabella or the nasal tip. They like to be at the suture lines. And we include both dermoids as well as epidermoids, both in this category. And their now better terminology is called the inclusion cysts in them. And they can have variable T1 and T2 signal depending on the presence of fat within them. They can have calcification. And one of the features which we describe is they can be associated with restricted diffusion, especially with the epidermal type of inclusion cysts. And one of the things that needs to be determined in these dermoid cysts is whether there is an intracranial extension, particularly if they are in the nasal glabella or the nasal tip, and that is the reason to do imaging to rule out intracranial extension. They can also happen in the floor of the mouth. You can be large, you can get dermal inclusion cysts, and they will usually be bright on T1, and it can be a differential or a challenging diagnosis from thyroglossal duct cysts, but thyroglossal duct cysts is always along the location of the descent of the thyroid gland. It will be at the base of the tongue, whereas dermoids can be typically a little more anterior in the floor of the mouth. And you can have this appearance, which has been described as a cluster of marbles appearance. But the case example that I have, these were just unilocular T1 bright lesions, which were dermoids. And the congenital tumor, which includes like all 4 layers of the embryonic germ cells, are the 3 germ cell layers are teratoma. And the common location is up in the neck and nasopharynx. And many of these are benign tumors and rarely can undergo malignant transformation. So whenever you see a very large mass in a young kid, even in a newborn, you can see heterogeneity within them. They can have fat, they can have calcification, they can have presence of tooth-like structures within them, really. But you can notice how it is pretty well circumscribed. So it's an example of a teratoma. You can identify teratomas on fetal imaging, and they can be seen as multiloculated masses, and they have solid or heterogeneous component, and presence of fat and calcification differentiates it from the lymphatic malformation. And here is an example. That was the fetal MR. This is a kid who was born with a large oropharyngeal teratoma. And this is one of the very impressive cases that I have. So this is on T1, you have heterogeneity, you have bright, fat-like material. And if you look at this cross-section, there was actually, you can see, what we hear about the foot and the mouth syndrome. This is actually part of an osseous, long bone within the mass. And this is, this was, we did CT for that, and you can see, the remnant inside, all these material within this large mass. And this is how it was laying. And this is another osseous structure, which looks almost like a scapula. So this is really one of the most impressive teratomas that we've seen. And this is how it was on the gross specimen. You can actually identify some parts of, well-formed portions or appendages. And this is, the bony structure that we were found in it. So one of the questions that was raised was whether this was a fetus in fetu. And the definition was that it did qualify for that. And you call it a fetus in fetu when you see at least, well-formed appendages and some portions of the calvarial elements. So this, which was initially called a teratoma, was then labeled more like a fetus in fetu. So that was one of the most impressive cases that I had seen. Briefly touching on some other entities like Langerhans cell histiocytosis. It used to remain an entity whether it was not clear whether this is inflammatory into neoplastic territory. Now it has been confirmed as a neoplasm. The hallmark of this is punched out lesions in the calvarium. You can see them on radiographs. On the CT scan, one of the features is the very clean or the beveled edges that you can get with these areas of destruction. You don't see anything like it's really clear cut, sharp margins with beveled edges and associated soft tissue mass. This is an example of when they're solitary, they can used to be called eosinophilic granuloma, and they produce these lytic geographic areas of destruction in the calvarium. Another site, which is very common, is the orbit. Again, notice the very clean margins of destruction. It's a common location to see it in the orbit. So when you see this very clean destruction in a young patient with this orbital lesion, then think of Langerhans cell histiocytosis. It also involves can involve the pituitary gland and result in diabetes insipidus, stalk thickening, and rarely can involve even the brain parenchymal lesions. There can be spine lesions and other areas of bony involvement when it is more widespread type of Langerhans cell histiocytosis. And a common tumor, which the tumor-like masses, which you should remember in the newborn, is fibromatosis coli. This is a diagnosis which can be made on ultrasound as well. It's a non-neoplastic condition, and it is actually due to fibrocollagenous infiltration of the sternocleidomastoid muscle. And usually you see it as a very non-tender, homogeneous appearing mass, can be identified in the region involving the sternocleidomastoid, and very uniform looking, homogeneous appearing mass on MR. So this should not be confused. It's a benign thing. It can resolve usually with conservative management. Physical therapy should not be confused for anything sinister. And the second type of branchial cleft cyst is another very common lesion. Usually will present in young, adolescents, teenagers, even in young adults. It can sometimes present, and it's the very classic location, which is kind of which is closely related to the carotid sheath, and beneath the sternocleidomastoid muscle. And if it gets infected, can have this rim type of enhancement. So this is an entity that you should always keep as a mimicker for neoplasms. So I think with that, I would just draw some closing points, which include that you can make a diagnosis of these lesions closely as much as we can, depending on the age. History is very important. Whatever information you have from the clinical examination, take into account if there are any genetic predispositions. And a multimodality imaging is the way to go, and they are usually complementary. And sometimes ultrasound, it is accessible if it is a superficial lesion. Radiographs are less common. CT scan, and sometimes we need to use the MR. Of course, I've just not listed it here because these are the ones with the radiation, and you can sometimes need angiography. MR is the gold standard in most of these soft tissue neoplasms of the head and neck. And you make use of the different characteristics on the sequences. You make use of contrast, diffusion imaging, ASL imaging, and susceptibility weighted imaging to try to characterize the lesion and come to a more narrow diagnosis. And at least it is also just important to, first of all, differentiate between benign and malignant lesions. You may not be able to tell the exact subtype, but at least you can describe the lesion, the location, its extent, and look for any features, aggressive features, if it has features for a malignant lesion and regions of spread, either perineural or lymph node. And you also make use of SPECT CT and PET CT as a part of the as a complementary to this investigations. And always remember, in the pediatric age group, you want to make judicious use of modalities with radiation, and also use sedation, anesthesia, and contrast wherever and whenever just needed. So with that, I think this is the end, and I'm getting some messages here from Dr. Kavita. So I actually had, I think, a couple quiz cases. I don't know, do you want me to show that, or I can even end here, whatever you say.
Please go ahead.
Sorry?
Please go ahead.
Okay, all right. So I think these are all, very nice to have in the live setting when you actually have people, in the audience. I can see, but I think this is an exercise which we all can just do, remotely. And so this is the first case. Now this one is a 14-year-old female who presented with a large painless neck mass. And I have deliberately withheld the history and I will show it to you in a minute. So just think about this. And this is this painless large neck mass has come over a matter of a few weeks after a very significant surgery, a major liver surgery. And I know you may be guessing and going in the right direction. They had a liver transplant. Now, in that with that history, what would you think about this mass, which has developed almost about 8 months after the initial surgery? So I think most of you may have guessed it. We are talking about the post-transplant lymphoproliferative disorder, or PTLD. And this is due to uncontrolled lymphoid overgrowth, typically in transplant recipients or people on immunosuppressive therapy. And the spectrum of disease, it can be just hyperplasia, or it can actually be frank malignancy. So think about it in post-transplant patients, usually the first year after the transplantation. Okay, that was PTLD. And this is the second case. And this is a 11-month-old female with a submandibular mass. This is the mass lesion. I will leave you to look at these. This is the T2 weighted stir image, and this is a post-contrast image to look at this case and form your diagnosis. In this case, I don't think any other history is needed, and I will give that just a minute. Just up here and go to the answer. This is actually ectopic thymic tissue. And the clue here was that this mass lesion has exact imaging characteristics like the mediastinal, the thymus in the mediastinal region. And we get these cases, sometimes from outside, unfortunately, they're mistaken for more malignant lesions and they undergo biopsy and unnecessary investigations. This is something which can be diagnosed even on ultrasound if they're amenable and accessible. So think of this entity when you see a very homogeneous soft tissue mass, well-defined, and try to see if this is if you especially do cross-sectional imaging to confirm that this has signal characteristics very similar to the native thymic tissue. And I had just a couple questions. I think since I have it, I'll just quickly run through them because these are some of the summarizing points of the talk. So which is the most common malignant tumor of the pediatric head and neck region? And these were the options. And the answer is lymphomas. So they are the most common tumors in the head and neck. Rhabdomyosarcomas are second. Hemangiomas are the most common benign tumors. And squamous cell carcinoma, this is a tumor which is more common primary malignancy in the adult population. And the second question was, which of these statements are true regarding juvenile nasopharyngeal angiofibroma, except there is to identify the false statement. And these were the options here. And the answer to this is the very first statement, because they do not occur in females, because there is a role of androgens and other factors which are involved in the development for this tumor. So this is a tumor of young males, actually, and all the other statements about association with familial adenomatous polyposis, the location, and being very vascular are all true statements. And I think that concludes my talk, and I thank you very much for your attention.